All right, Lauren, so here is your orders to pick from. Please pick one. Okay.
Okay, it says to insert an NG tube for decompression for drug overdose. Okay, so because I'm going to be inserting a tube for decompression, I'm going to choose the Salem sump. And I know it's the Salem sump because it's got the little blue port on it. Okay, and then before I get started, I've got a drape, I've got some ice water for my patient, I got some tape set up, I got my pen light pH strips in my little container here. Okay, so I'm gonna get started. Hi, Mrs. Smith, my name's Lauren. I'm gonna be your nurse today. The doctor just placed an order to insert a nasogastric tube and to suck out, you know, all of that medication and stuff. To help you feel better. This procedure is pretty uncomfortable, I'm going to be honest with you. However, I know you're already uncomfortable, so the procedure itself can be very uncomfortable putting the tube in, but once it's in, you should feel so much better once we get all that stuff sucked out. So I have a cup of water over there for you because the most important thing you can do when I'm inserting this tube is to swallow. That's going to help the tube go down to where it needs to go, which is into your stomach. If you resist or if you're not swallowing, that just makes it harder for the tube to go. So the more you can work with me on getting this tube down, the better it'll be for the both of us. And then in the event that something doesn't feel right, you have pain, you literally cannot tolerate it, please just raise your right hand. I don't want you to hit me or pull the tube, so please just raise your right hand if you experience any extreme discomfort. Have you ever had a nasogastric tube before? Okay, you have not. I'm going to go ahead and shine this light in your nares real quick, and they both look patent, open. Look in the back of your mouth, that looks good. Do you have a history of esophageal varices or bariatric surgery or any like nasal trauma? No? Okay, good. Do you have a preference on which side of your nose I put this in? No? Okay, well, I'll opt for the right side just since I'm over here. And then I'm going to measure. So again, nothing you need to do right now, just kind of rest here while I get everything set up. So I'm going to measure from the tip of your nose to your earlobe, and then down to your xiphoid process. Okay, and I'm going to put a little piece of tape there, and that's just going to let me know how far to put the tube. And then I'm going to go ahead and put this on the end so I don't forget and so I don't make a mess. And then let me get some lubricant here. And so I am putting some lubricant on this tube, Mrs. Smith. This will help the tube slide down real smoothly, okay? This plus you swallowing and tucking your chin when I tell you to, all of that will be extremely helpful. Okay, so as we get ready here, the first thing I want you to do is to tuck your chin, and then we're going to tilt your head back when I first put this in, and then once it gets to the back of your throat, which I'll tell you when, then I want you to tuck your chin and swallow that water, okay? So we're going to start again with your head tilted back. I'm going to insert this just to your nose. You're doing great. Okay, now I want you to tuck your chin and swallow, 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 swallow. You're doing great. And I would advance this tube all the way to where the tape is. You did so good. See, that was quick, and there's going to be stuff coming out of here shortly. You're going to feel so much better. So I'm going to go ahead and temporarily secure that. Again, it would be all the way to the tape marking. I'm going to get a chest x-ray to verify placement. That's the most reliable. But also while I'm here, I'm going to go ahead and check the pH. So I'm going to draw back a little bit of gastric contents. Try that again. Squirt a little bit in there. Okay, and the pH is at 4, so I know I'm in the stomach. And then since we're using this for decompression, I'm going to go ahead and hook this up to the suction. So I would hook this up here. There'd be another piece to connect it, but I would hook it up there and be able to turn on the suction. Some other ways that I could verify placement besides the chest x-ray and the pH test would be the whoosh test. And that is where I'm using a stethoscope. Thank you. I'm using a stethoscope. I could drop about 10 to 20 mLs of air. Just checking on your tube, Mrs. Smith. Everything is fine. I'm going to listen in the left upper quadrant and inject this air, and I should hear a whoosh sound. However, because this is in for decompression, I've hooked it up to suction. I can clearly see gastric contents coming out. Okay, and then additionally, I could add a piece of tape here and then use a safety pin to pin this to the patient's gown. And then something else I could have done was like use an alcohol prep pad to clean the nose before I stuck the sticker on there. Or I guess I could do it now before I secure this tube further. So I'd prep with some alcohol pad or skin prep, and then I'm going to go ahead and reinforce this on the patient's nose. And then I would document in the patient's chart which nair, which size tube, and then the centimeter marking. And because this tube does not have centimeter markings on it, most of them do, but if it doesn't, then I can measure from the nairs all the way to the end of the tube, which is 29 centimeters, and that's what I could document as well.
All right. Awesome. The doctor has ordered an irrigation of the nasogastric tube for you.
Okay. And then, okay. And then of course in real life I would be using this tube to irrigate for decompression, but I'm going to be using this one. And so checking placement is always important, but it's obvious that this is in place because I can see the gastric contents, but I could always take a small sample of that, test the pH again as well, or verify my chest x-ray. I'm going to go ahead and pour 20 mLs of normal saline, making sure I choose normal saline. Up to the end of my NG tube. I'm going to push in the 20, and then I'm going to remove it. And then I would discard this. And indications for irrigating would be like if I saw that there was no drainage coming out, or if the drainage looked like it was clogged, or if my patient was nauseous or something like that, might be an indication to do this. Or sometimes the doctor just orders it to be done once a shift. And so then I would plug this back up and hook the patient back up to suction. I would discard this, of course. Okay. Oh, and then if I'm using the Salem sump, which has the blue port, I would inject 20 mLs of air into the blue port before I hooked it up to suction. If it is a Levine tube like this, there's no purpose in injecting the air. This could be only used for intermittent suction. This could be used for continuous, but yep, I would inject the air into that blue port before I hooked it up to suction after I irrigate.
All right, great. Now here is your pick of orders.
Okay.
For what you are going to do for administration.
Okay, it says to administer 40 milligrams of Practimed via G-tube. Okay, I'm gonna wash my hands again. I'm gonna double check my order just like I would with any and all medications. So the doctor has ordered 40 milligrams of Practimed. And here I have Mrs. Smith. Her MRN, her date of birth is all correct. And this is 20 milligram tablets. So she'll have to get 2 of those. And then I would verify that this medication can be crushed, which it can. And then before I get started with my medication administration, I am going to set my patient up in high Fowlers. I'm going to go ahead and listen to bowel sounds. In all 4 quadrants. Good, I'm hearing some good movement. That's great. Okay, good. I have positive bowel sounds. And so then the next thing I would do is check placement. Again, I can do that with an x-ray, a pH strip, which I demonstrated, the whoosh test, or just looking for the gastric contents. And all of that comes back okay. So now I'm going to go ahead and check residual. So I'm going to hook up my syringe and pull back. And I'm getting just a drop or 2, so maybe like 1 to 2 mLs. And I'm going to go ahead and put that back in. And then I would plug this, of course, when I'm not using it. Okay, and now I think I'm ready to get my medications ready. All right, and so I'm gonna pour, I don't know, about 100 or so of water. I think I'll do 150 just to make sure I have enough in between each med. Okay, and then it is preferred that we administer each medication separately, but if it was the same med, I could, as long as it's not too big, I could potentially administer that at once, but I'm gonna do these separately just for good measure. Again, the order is 400. I'm gonna put my other one over here. And these are 200 milligram tablets, so I'm going to be giving 2. Go ahead and crush this. And I mentioned I would make sure that the medication can be crushed, but some medications that cannot be crushed would be like capsules, enteric-coated, extended release, hydrophilic medications. And this is a perfectly crushable medication. All right, let me add some water here. All right, I did bowel sounds, checked placement, checked residual. Yeah, I think I'm ready. Mrs. Smith, can you tell me, verify your name and date of birth? Great. I'm gonna go ahead and scan these medications into the MAR. And then I'm gonna take this plunger out because I'm gonna do this by gravity. I'm gonna start with some water to flush. Going down perfectly. Give this first medication. Going down good. Flush after the med. Good. Give the next medication. Good. Give another flush. Good. And then if there's any medication residue, I can use my last bit of water just to make sure I get it down. And then I'm going to finish with a flush. And then for documentation purposes, I would put that the residual was 2 mLs and that I administered 150 of water. I would plug this again while I'm not using it. Make sure my patient stays sitting upright for at least 30 minutes afterwards. Okay.
Great. Now you can go ahead and remove.
Okay, good. All right, so the final step. I'm gonna wash my hands, get a new syringe. Okay, get a new syringe. Wash my hands, not introduce myself, put some gloves on. Hey, Mrs. Smith, I'm back again. The doctor has ordered for us to take your nasogastric tube out. So I'm gonna get us ready to do that. So I'm gonna get a little drape ready for you, maybe some tissues in case you wanna wipe your nose after we get this out. And then I'm gonna make sure you haven't had anything to eat in the last hour, have you? No? Okay, good. So I'm gonna draw this up to like 10 to 20 mLs of air. I'm gonna go ahead and inject the air, clear the end of the tube. I'm gonna go ahead and carefully remove this tape. And pin it from the patient's gown. All right, Mrs. Smith, this is gonna be easy getting this out as opposed to when it went in. So really all I need you to do is cough or breathe, cough or hold your breath when I take this out. So I'm gonna say on the count of 3, and then I want you, well, what do you wanna do? Do you wanna cough or hold your breath? Hold your breath? Okay. So I'll count you down. I'll say 1, 2, 3, hold your breath, and then I'll remove the tube. All right, here we go. On the count of 3, 1, 2, 3, hold your breath. All right, very good. The tube is out. You can go ahead and cough and wipe your nose. And then I would document that I removed the tube, of course. And then we'll just keep a close eye on you, Mrs. Smith. Please let me know if like you're feeling nauseous or anything new is going on with your stomach. But your nose looks good. I don't think you need any cleaning up there. So you should be good to go.